speakers. Our agenda for the evening is the majority of the webinar will be led by Dr. Cujec and Dr. Koshman, going over the material on screening and prevention. We will have about 10 minutes for a question and answer period, and then we will go into an application of learning section where you will be put into a facilitated breakout room and supported to complete an action plan related to applying the material we've learned today to making practical change for patients at risk for heart failure in primary care. This workshop is CME accredited. You can earn up to 2 CME Main Pro Plus credits per hour for attending this workshop and completing the follow-up action items. And you will receive, following the workshop, a certificate of attendance for the CME credits and a record of hours where you can track the items of attending the webinar, putting your action plan into place, and meeting with your PCN improvement facilitator to finalize, implement, and evaluate your action plan. Those meetings can happen over email, over phone, over Zoom, whatever works best for you. By completing all of these items, there's up to 5 credits available. So I'm going to welcome Dr. Cujec to start us off on the talk here. Thank you.
Hello, and thank you for attending this workshop on screening and prevention of heart failure in primary care practice. I'm Bibiana Cujec. I'm a cardiologist at the Mazankowski Alberta Heart Institute, and I've been working in the Heart Function Clinic for many years, and I'm sure we have worked together with some patients who are in your practices and that we see as well in our multidisciplinary heart function clinic. And we're hoping that earlier detection and diagnosis of heart failure will lead to improved outcomes for these patients. So first of all, I have no disclosures other than being an employee of the University of Alberta. And Sheri Koshman is a PharmD who works with us in our heart function clinic, and she has some disclosures, as you can see in this slide. There's no potential for conflict of interest from financial support received from the Office of Lifelong Learning. And the learning objectives in this session was developed and reviewed by a planning committee. So the learning objectives are to explain the diagnostic classification of heart failure, including a new classification that has just come out this past month, use CCS guidelines for the diagnosis of heart failure based on signs, symptoms, echocardiography, and especially the biomarker B-type natriuretic peptide. Identify patients at risk of developing heart failure and institute measures for risk factor modification, and apply an evidence-based approach to identify patients with risk factors for heart failure and offer screening and prevention resources. So first of all, the definition. Heart failure is a complex syndrome in which abnormal heart function results in clinical signs and symptoms of low cardiac output and/or pulmonary congestion or systemic congestion. Now, this has been the classical definition of heart failure, but it is very difficult to apply to clinical practice because what are the signs and symptoms of low cardiac output, and really how specific are they? And likewise with pulmonary or systemic congestion, peripheral edema can be due to venous insufficiency, not necessarily heart failure. So the new universal definition of heart failure from the Heart Failure Society of America, much like the universal definition for myocardial infarction, also requires some more objective clinical data. Heart failure is a clinical syndrome with symptoms and signs caused by a structural and/or functional cardiac abnormality and corroborated by elevated natriuretic peptide levels and/or objective evidence of pulmonary or systemic congestion. And we'll go over that in more detail. But note the importance of natriuretic peptide levels. So the heart failure classification has also been updated a little bit, and I'll go into some minor changes. So first of all, the ejection fraction is most important in terms of classifying heart failure. And the ejection fraction, we need to do an echocardiogram usually to obtain that result. A cardiac MR will also give you that information very accurately. So heart failure with preserved ejection fraction is diagnosed in patients who have an ejection fraction more than 50%. Heart failure with mid-range ejection fraction or mildly reduced ejection fraction in the new classification are those patients who have an ejection fraction of 41 to 49%. And heart failure with reduced ejection fraction are those who have an EF of less than 40%. Now, there are some patients who have reduced ejection fraction and improve, usually with specific therapies or sometimes just with treatment of atrial fibrillation or elimination of alcohol. So those patients may have recovered ejection fraction, or in the new classification, improved ejection fraction. So those are patients who previously had an EF of less than 40% and now have an ejection fraction of more than 40% on at least 2 separate measurements over a period of time, and an improvement of at least 10 percentage points. And those patients still don't have a normal left ventricle and need to continue on beta blocker and ACE inhibitor because of the risk of recurrent low ejection fraction. So this is the CCS recommendation in terms of assessment and then determining the etiology of the heart failure. So it is recommended that patients with suspected heart failure have an echocardiogram, ECG, and CBC, creatinine, ferritin to exclude hemochromatosis, TSH, troponin, and natriuretic peptide. And then patients are divided into those with reduced ejection fraction or mildly reduced ejection fraction. So basically an ejection fraction of less than 50%, those with preserved ejection fraction, and patients with congenital heart disease and pericardial disease resulting in heart failure are in a separate category because they have more specific treatments in terms of managing the structural abnormality, or in the case of pericardial disease, usually pericardial stripping. The common etiologies for both HFrEF and HFpEF are valve disease and coronary artery disease and left ventricular hypertrophy, usually from hypertension, and tachyarrhythmias like atrial fibrillation. Less common etiologies for HFrEF more specifically are familial cardiomyopathies that have a genetic basis, or toxic agents like alcohol. These are the most common ones: alcohol, amphetamines, cocaine, steroids, chemotherapy at any time in the past, radiation therapy, and then peripartum cardiomyopathy. Very important to detect infiltrative diseases as well, like amyloidosis, usually a normal ejection fraction or only mildly reduced, but increased thickness of the left ventricular walls. And this is important because there are more specific therapies now available for certain types of amyloid, especially when detected early. Very important to use this classification and to correctly classify patients as HFrEF or HFpEF, because the therapies, the disease-modifying drug therapies that we have, impact mortality only in patients who have reduced ejection fraction. So, you'll be hearing more in the second workshop, but beta blockers, ACE inhibitors, mineralocorticoid receptor antagonists improve survival and improve symptoms and ejection fraction in patients who have reduced ejection fraction only. In general, ambulatory HFpEF patients have a better prognosis, and the causes of death are different in patients with HFrEF who die either of arrhythmias or multi-organ failure versus HFpEF patients that are a much more diverse group of patients, often obese, often with hypertension, diabetes, renal failure, obstructive sleep apnea, so many more comorbidities. This is a score that's been validated for diagnosing patients with HFpEF. And of these 6 criteria, 2 are based on echocardiography, but I just want you to focus on the clinical factors that are associated with HFpEF. So obesity, a BMI of more than 30 kilograms per meter squared, hypertension with being on more than 2 antihypertensive medications, atrial fibrillation, and age greater than 60 years, all increase significantly. If you just have those 4, you've got 6, 7, so you're in a high probability of HFpEF with just those 4 clinical factors. Now, the signs and symptoms of heart failure relate to decreased cardiac output and pulmonary congestion for left heart failure. And pulmonary congestion manifests itself as cough with frothy sputum, often occurring during the night, and the patient either sleeps in a lazy boy or has several pillows that they prop their chest up on, with paroxysmal nocturnal dyspnea, awakening during the night and needing to sit up or stand up for a short period of time, go to the window in order to be able to breathe better. The most common cause of right heart failure is actually left heart failure with the development of post-capillary pulmonary hypertension. And once you develop right heart failure, you have a lot less pulmonary congestion because the right ventricular stroke volume is decreased and there's less filling of the left heart. But you develop severe congestion of peripheral tissue, so the liver becomes congested, and patients complain of right upper quadrant pain, of early satiety. There's a lot of ascites that develops and edema that can extend from the feet up to the groin. Anorexia, weight loss become common. Not so much weight loss because they do gain water, they're very edematous, but definitely muscle loss. Top 3 symptoms of heart failure are dyspnea, edema, and cough. There's another symptom of heart failure that is relatively newly described, and that's bendopnea. And bendopnea is when a patient, usually they'll tell you when they're tying their shoes, they get very short of breath. But to bring on this symptom, you ask the patient to sit in the chair, bend at the waist, and touch his or her feet. And what that does is it compresses the inferior vena cava and results in increased venous return to the heart. And if the patient already has an elevated filling pressure, like an LV diastolic pressure that's a little high, over 18 millimeters of mercury, that increased venous return to the heart will result in a significant rise in the filling pressure such that the patient becomes short of breath. And we had a question about whether this is valid in obesity. And of course, obese patients have a lot of difficulty bending over, so I don't think it would be a good sign in an obese person. The signs of heart failure on physical exam will depend on whether the patient has decompensated heart failure, so fluid overload, or whether they're well compensated. So the physical exam can be completely normal, or if they have high filling pressures, they will have a high jugular venous pressure. This is the external jugular vein. And often they will have some pitting peripheral edema. And we listen for pulmonary crackles as well. This high JVP is specific for elevated filling pressures in the right atrium. So it's a very good sign, but sometimes a little difficult to elicit, especially in patients who have thick necks. The ECG, again, is not specific, but it's rarely normal in patients who have heart failure. It's common to have a left bundle branch block or left ventricular hypertrophy, and arrhythmias, premature ventricular beats or atrial fibrillation are common. The chest X-ray can show increased lung water, so bilateral pleural effusion, some interstitial edema, some vascular redistribution if the patient has decompensated heart failure. And of course, we'll also give you some information about cardiomegaly, but a lot less sensitive or specific than an echocardiogram. Now, B-type natriuretic peptide is the key biomarker for heart failure, and this has been a wonderful addition to our ability to accurately diagnose heart failure in patients who are short of breath. So B-type natriuretic peptide is released from the ventricular myocytes when wall stress is increased. So whenever there's an increase in filling pressures in either the right ventricle or the left ventricle. And B-type natriuretic peptide is derived from pro-BNP that's cleaved into the active molecule BNP and N-terminal pro-BNP. And that's important because in Alberta, in the Calgary region, it is the NT-proBNP that's measured, so the inactive molecule. And in the Edmonton region, it's BNP, the active molecule, that is the assay used. So BNP is very useful for the diagnosis of heart failure in the emergency department if the BNP is more than 500. It has both diagnostic and prognostic values. So the higher the BNP, the sicker the patient. And also in terms of response to therapy, if the BNP comes down, the patient is responding to therapy and has a better prognosis in general. Now, there are false negatives for BNP. For very acute pulmonary edema, there just isn't enough time to increase the synthesis and release of BNP. Patients with mitral stenosis who have low left ventricular wall stress will also not have elevated BNP. Obese patients have a low BNP. And pericardial diseases, also those patients have a lower BNP. It's important to realize that BNP increases with age, is higher in women, is higher in patients with atrial fibrillation, and is also higher in patients who are on a very beneficial drug, Entresto, sacubitril/valsartan, because sacubitril prevents the breakdown of BNP. So the recommendations in terms of the cutoff points for BNP and diagnosis of heart failure. So BNP of less than 100, actually less than 50 is what the Canadian Cardiovascular Society uses. Heart failure is unlikely. And then in the 100 to 500 picogram per milliliter range, it's possible, but not definite. And over 500, heart failure is very likely as the cause of this person's dyspnea. Now, the values for NT-proBNP are generally higher for different ages. So with different ages, you can see the heart failure diagnosis increases significantly with the NT-proBNP and much higher values in general, about 3 times as high for NT-proBNP than BNP. So important to know which natriuretic peptide is being measured and what the normals are, or what the cutoffs are. And in terms of the likelihood ratios, if you have a patient who has a low pretest probability of heart failure, let's say in the 20% range, then the positive likelihood ratio is about 3 to 4, and the negative likelihood ratio is about 0.1. Echocardiography is always required in patients with either suspected or definitely confirmed heart failure. And that's to get an assessment of the ejection fraction so that we can tell whether the patient has HFrEF or HFpEF, to see whether there's any valvular disease like secondary mitral regurgitation or primary valvular disease as the cause of heart failure, and to assess chamber size, presence of pulmonary hypertension. So very important test for confirming the diagnosis of heart failure, assessment of potential etiology, and complications of heart failure. In terms of the diagnosis of heart failure in ambulatory care, it is important to make the diagnosis, and there's opportunity to make the diagnosis to prevent hospitalizations, because we know that once patients are hospitalized with heart failure, they have increased mortality, possibly because it's just a more advanced stage. But this was a very interesting study from Doug Lee and the group at the Toronto General Hospital looking at the Ontario database at patients with new incident acute heart failure hospitalization and the number of healthcare contacts they had in the year preceding their admission to hospital. So you can see patients who are admitted with acute heart failure here with the red boxes, patients with chronic obstructive lung disease who required a first hospitalization, and then patients with stable heart failure. So patients with stable heart failure generally have slightly more than one healthcare contact per month, and that's defined as either seeing a physician or an emergency department visit or a hospitalization for an unrelated reason. So generally about one, but in the month or the 28 days prior to hospitalization, that goes up to about 1.8. So there's an increase in visits prior to hospitalization. And that's particularly true in younger patients, those in the 20 to 40-year-old range in blue here. So they had almost 2.5 healthcare visits in the month preceding their initial hospitalization with heart failure. And a lot of the time, this is attributed to asthma, an acute viral illness. Heart failure is just not considered likely in a younger person. And of course, that's true in that it is mostly older people who have heart failure, but there certainly are young patients with myocarditis or familial history, or the other big one is substance use disorder, like amphetamines or cocaine or alcohol. So let's look at a case that you might see in your clinic. A 70-year-old woman has recurrent visits to a walk-in clinic with upper respiratory tract symptoms. She's treated with a course of antibiotics and given bronchodilators. She's a smoker and is on a nicotine patch. Now she has worsening exertional dyspnea, some wheezing, some abdominal bloating. She's unable to sleep at night when she tries to lie flat. Her blood pressure is a little high. Heart rate is at the upper range of normal. A few wheezes, a few creps, tender in the right upper quadrant. So you ordered the usual blood tests and you wonder, is this heart failure or some other diagnosis? Well, she certainly has symptoms and signs that are consistent with heart failure. This is the algorithm that the Canadian Cardiovascular Society recommends. So she has some symptoms of shortness of breath. On physical exam, we'll look whether there's any peripheral edema and what the jugular venous pressure is. We order some blood work. So we do suspect heart failure here. So it's recommended to assess the natriuretic peptides, and that is available in Edmonton. And the turnaround time is definitely within 24 hours. In the emergency department, we get it within an hour or two. And so if a BNP is greater than 50, so quite a low cutoff, then the recommendation is to assess further with an echocardiogram. And then depending on what the ejection fraction is, treat accordingly. And some patients, of course, will require other testing like cardiac catheterization, if coronary artery disease is suspected, or a pyrophosphate scan, if amyloid is suspected. So different tests to determine the potential etiology. Genetic testing also, of course, being very important. So the physical exam, the BNP will be really important. So in her case, the ECG shows sinus rhythm with the left bundle branch block. The chest X-ray shows mild cardiomegaly with increased interstitial marking, so some pulmonary edema. The creatinine is increased to 120, and the BNP is definitely high at 790 picograms per milliliter. The echo comes back, and the ejection fraction is in the mildly reduced or mid-range ejection fraction. So definitely has heart failure because of the elevated BNP. And this heart failure is mildly reduced ejection fraction. So we treat these patients as we do those with reduced ejection fraction. So BNP is extremely helpful because the symptoms and signs of heart failure, some of the signs, are not specific. So dyspnea, of course, could be due to COPD exacerbation, asthma, physical deconditioning with aging, and decreased activity, pneumonia. Fatigue is also very common with aging, but is also a sign of low cardiac output. And leg edema can also commonly be due to venous insufficiency and varicose veins, but these conditions should not result in elevated BNP. So here's 2 cases of patients who have a low normal ejection fraction, 50%. One is an elderly woman with hypertension, atrial fib, stage 3 chronic kidney disease, comes in with shortness of breath and fatigue, and she's quite slim. She has leg edema. And then these are 2 different phenotypes that are very common in heart failure, preserved ejection fraction. 62-year-old man, diabetes, smoker, he's also short of breath and tired. His BMI is in the obese range. He has leg edema, a normal ejection fraction. So how will we know if these patients have heart failure as a cause of their symptoms and sign? Well, the BNP is really important. They might both have HFpEF. So the definition of HFpEF that the CCS developed was the presence of symptoms and or signs of heart failure with a preserved ejection fraction and elevated levels of natriuretic peptides. And the natriuretic peptides are never as high in HFpEF as they are in HFrEF, because these are generally smaller ventricles with lower wall stress. So a BNP of more than 50 or an NT-proBNP of more than 125 is enough for the diagnosis of HFpEF. So I will end there and turn it over to Sheri.
So I'm going to talk a little bit about prevention. And I wanted to start off with kind of reviewing this schematic. And this is kind of what the Americans use in terms of classifying heart failure. And it's useful because, as we know, some people will have heart failures and their symptoms will vary. They'll have symptoms or their symptoms will go away, but they will always have heart failure. This is a schematic to then incorporate thinking about those patients who don't have any heart failure and may have some structural problems. Versus those people that actually have had signs and symptoms of heart failure. So who is at risk of heart failure? So there's a number of risk factors that put people at higher risk. And this is a study that looked at trying to quantify what is the risk associated with certain risk factors. So age is the #1 risk factor, and we know that people over the age of 65 are more likely to develop heart failure. The average age is about 73, and the risk increases as age increases. Hypertension, MI, angina, and diabetes are all well correlated risk factors to heart failure. In addition to that, we see that left ventricular hypertrophy, as well as atrial fibrillation and COPD, are also clearly associated with risk of heart failure. So when we think about prevention of heart failure, so stage A is true prevention. So these patients have no signs and symptoms of heart failure. They are high risk, but they don't actually have any structural disease either. So this would be people that are at high risk of developing heart failure in the future. So risk factors for atherosclerotic cardiovascular disease, such as hypertension, obesity, diabetes, and metabolic syndrome. Those people that have exposures to cardiotoxins, as Dr. Cujec had alluded to, so chemotherapy and other agents, and those patients who have a family history of cardiomyopathy are at higher risk. And our goal in these types of patients are really healthy behavior promotion, prevention of atherosclerotic cardiovascular disease, and then preventing any LV structural abnormalities. In terms of interventions, so classic interventions for healthy behaviors, as you all know, exercise, smoking cessation, moderating alcohol intake, and weight management. We want to try and prevent atrial fibrillation as well as sleep apnea, as we know those are risk factors for heart failure, specifically HFpEF. Want to think about preventing atherosclerotic cardiovascular disease, so risk factors such as dyslipidemia using statins. When we think about diabetes, we want to prevent and treat diabetes, but if we are going to treat them, thinking about agents that perhaps decrease risk of cardiovascular outcomes, such as SGLT2 inhibitors and GLP-1 agonists. And we generally try and avoid saxagliptin and TZDs. Both of these agents have been associated with higher risk of heart failure. We want to treat and control hypertension, ACE inhibitors and ARBs, and other antihypertensives to decrease the blood pressure, and consider ACE inhibitors and ARBs in terms of vascular protection in these patients. Of course, avoiding toxins such as cocaine, amphetamines, and heavy alcohol intake. And then we also, in those patients that are undergoing chemotherapy and those chemotherapeutic agents that are at high risk of LV dysfunction, we want to employ early detection and screening of these patients to either prevent it or treat it as soon as we see it. So this is a little study that was recently published that looked at how do we identify those people, let's say, with diabetes that are at particularly high risk of developing heart failure. And so this was a biomarker study that developed a risk score and looked at high-sensitive troponins, NT-proBNPs, high-sensitive CRP, and LVH by ECG. And essentially what they were able to show is that you got 1 point for every elevated biomarker. And what they were able to show is that these points were correlated to risk of developing heart failure in the future. And this was in both people with diabetes as well as pre-diabetes. So the higher your score was, the more likely you were to develop heart failure. So just interesting data for us to then further subcategorize patients and identify those that are high risk and potentially treat them earlier, focusing on perhaps some of those diabetic medications that decrease cardiovascular risk. Now I wanted to move on to stage B. So stage B is different than stage A in that there is actual structural disease, but there are still no symptoms of heart failure and have never been any symptoms of heart failure. So these patients might be those patients who've had a previous MI, have scar and some LV dysfunction, but they haven't actually had heart failure symptoms. Patients who have LV remodeling, such as left ventricular hypertrophy or a low EF, so these could be those patients who have poorly controlled hypertension, or those patients who have asymptomatic valvular disease. As their valve disease progresses, this may cause some LV dysfunction. And in these patients, our goal is to prevent signs and symptoms of heart failure, and then again, prevent further remodeling if that is already present. Our interventions are similar to stage A, healthy behaviors, looking at atherosclerotic CV disease risk factors, so dyslipidemia, statins, diabetes, same treatment, hypertension, same treatment, and vascular protection is the same. And we want to specifically treat LV dysfunction with ACE or ARB plus beta blocker. So all these patients should be on those two agents, despite not having symptoms of heart failure. Now, I just wanted to take a very brief opportunity to highlight some of the data around SGLT2 inhibitors because this is coming at us fast and furious. There's been a number of studies in patients who have diabetes plus cardiovascular risk factors, as well as patients with diabetes and chronic kidney disease or just chronic kidney disease alone, looking at the impact of SGLT2 inhibitors. And what all these studies have actually shown was despite the population that was enrolled and the reason why they were using the medication, which was mostly for diabetes, what they found was that they had a decrease in heart failure outcomes, so cardiovascular deaths as well as heart failure hospitalizations, which is fairly consistent across all these studies. At first was a little bit surprising, but now with the more studies that are published, we see that this is a consistent outcome. And keeping in mind this is primary prevention, the majority of these patients in these studies did not have heart failure when they entered these studies, or at least it was not detected or reported. And what we see is a fairly significant benefit in terms of number needed to treat in preventing heart failure. So anywhere between 125 to 42 over 2 to 4 years of treatment. So pretty significant, and we should really be trying to prioritize these agents in these patients to prevent these outcomes. I just wanted to just briefly share this tool, and this is developed by the Canadian Heart Failure Society, and it's on their website, and it's basically a practical approach that you can print out and post up that helps you think about how we might start these agents in these patients, and whether it's treating heart failure or for preventing heart failure and treating cardiovascular diseases. So I won't go through the details, but just wanted to highlight it as a resource for you. There, okay. So I guess just to conclude, who do we screen? So we want to screen patients with exertional dyspnea, exercise tolerance, and have risk factors for heart failure. So these being age, coronary disease, vascular risk factors, cancers, or toxins, as we've talked about. How do we screen these patients? Well, we do an ECG, chest x-ray, and blood work, including CBC, TSH, creatinine, electrolytes, glucose, and the urinalysis would be kind of the preliminary screening. If they you have a high suspicion or you need to rule out whether heart failure is present or not, we do a BNP. And then if it is elevated, then proceed to an echocardiogram. How do we prevent heart failure? Well, we want to first identify the patients who are at risk. We want early detection of these patients who have elevated systolic dysfunction, and those people we should for sure be treating with beta blockers and ACE inhibitors. We want to treat their risk factors, including hypertension, dyslipidemia, diabetes. And eventually what we want to do is really prevent them from having any acute myocardial infarction or acute coronary syndromes that would predispose them to having cardiac dysfunction. And in those patients with diabetes, we should be giving preferential treatment to using SGLT2 inhibitors to prevent cardiovascular events and heart failure hospitalizations, even in those patients who don't actually have heart failure at baseline. And then there was just some references that we added in here, the CCS guidelines. The 2021 guidelines will actually be published on April 6th, so they'll be updated. So look out for those. And then the new definitions for heart failure just recently published, the references there as well. And I see that there's a question here. Do you think Alberta Blue Cross will start covering SGLT2 inhibitors without requiring patients to use insulin first? I think the answer to that at the present moment is no. I always find that saying needle phobia is helpful on the forms. I doubt that they will change that requirement, so there is still some hoops to jump through for sure for that. Other question here is, what about SGLT2s for non-diabetics with heart failure? So we'll discuss this in more detail at the next session in April, but yes, there's lots of evidence coming out, 2 major trials with dapagliflozin and empagliflozin in people who have HFrEF with an ejection fraction of less than 40 and have symptoms class 2 to 4 heart failure, using an SGLT2 on top of conventional therapy. So ACE, ARB, ARNI, beta blocker, MRA, adding an SGLT2 decreases heart failure hospitalizations and cardiovascular death. So there's good evidence it's no longer just a diabetes drug, but we'll go into more detail next time on that. Good question.
Great question. We had another one here. I'll just read them out from the chat. Bendopnea, what about if the patient is obese? And maybe Bibiana, if you want to come off mute to respond to that one.
Hopefully I won't cut out again. But even if a patient is obese, like bending as much as they can. Obviously, if they can't bend over, then that you can't really look for that symptom. But a lot of people will tell you that they're quite short of breath when they bend over to tie their shoes, if they're able to do that. So it seems like a fairly specific sign for elevated filling pressures, as long as the patient can bend over.
Thank you. We had another question related to bendopnea around how specific it is for heart failure.
Well, when it was initially described from Harvard, it was correlated with pulmonary capillary wedge pressure, so direct measurement of left ventricular diastolic pressure. And it does seem pretty specific to elevated filling pressures. It's kind of like if a patient becomes more short of breath when you lie them flat, you know, they have orthopnea. So people are more comfortable sitting up. I mean, it's absolutely not specific for heart failure, but it is suggestive that they have higher filling pressures.
Thank you. I believe this question did get answered in the chat about family physicians. Can they order a BNP on outpatient basis? And I believe Anne said that was correct, but we had a follow-up question on whether or not that could be made on a regular DL lab form.
I believe it can. Like, we certainly order it routinely in outpatients, and I don't think there's any restriction in terms of who can order it. In terms of the lab form, I can't really address that. Like, we're on Connect Care.
Yeah, it's just a regular DynaLife requisition, and you add it in the additional section.
Great, and Sheri, you already answered that question. We do have another question here. I have a patient, 72 years old, no SOB, but worsening pedal edema. Long history of hypertension on ACE, SCCB, diuretic, obese, BNP of 292. All other lab tests are normal, awaiting echo. How would I go about treating him?
Oh, I would say increase the diuretic. So this is a person who is obese. So that BNP of 300 in a person with a normal BMI would probably be in the range of 600 or so. So potentially the calcium channel blocker may also be worsening the pedal edema, but I would say I would increase the diuretic to start off with.
Great. Even if a patient has no HTN but have systolic heart failure, can they be started on an ACE or a beta blocker? Would it be one or both?
It would be both. I mean, for HFrEF, patients should be on ACE inhibitors or ARBs and a beta blocker. So the question is which one you start first. I mean, you could potentially start both together, but in general, an ACE inhibitor is better tolerated. So I would start with the ACE inhibitor and titrate it up. Like, let's say you go with lisinopril, you know, start at 10 milligrams, go up to 20 milligrams, start with ramipril. It would be 5 milligrams once a day and then twice a day. Perindopril, 2 milligrams a day, and then you'd add the beta blocker to that. And the beta blocker, I mean, talk about that more in the next workshop, but the beta blockers in heart failure are metoprolol, bisoprolol, or carvedilol. So you would choose one of those three.
Great, thank you. We have another question regarding SGLT2. Well, a comment, more like when we were talking about coverage. Dr. Olson said that they had no trouble getting them coverage, indicating mortality benefit without trying insulin or sulfonylureas. I apologize for my pronunciation of that. All right, there was a question here. Are there some validated risk scoring systems to set pre-test probability? What is the range of likelihood ratios with the different BNP cutoffs?
Well, I don't know of any specific risk scores for like heart failure diagnosis. There's the HFpEF one, but you know, the higher the BNP, the more likely the patient has heart failure. So like if we want to get patients on angiotensin receptor neprilysin inhibitor in Alberta, they need to have a BNP of more than 100 at any time, or if they've been hospitalized, or more than 150 if they've never been hospitalized. So that's a pretty low BNP cutoff. Most heart failure trials have also used 100 or 150 as a cutoff, like at minimum level of BNP to be included in a heart failure trial. But yeah, I don't know of any, I'm sure it could be calculated, but yeah, I don't. Mostly, you know, most of the patients I see have heart failure, so I look at it more from a prognostic perspective, but BNP is extremely useful as, you know, rapid diagnosis to make the diagnosis or to exclude the diagnosis of heart failure. Like if the BNP is less than 50, for sure you can forget about heart failure at that time. That's not to say that the patient might not have a really high BNP at other times though. So BNP is like one point in time, an assessment of filling pressures. And patients with severe heart failure, if they're well treated and respond well and kind of have heart failure in remission, then their BNP can be normal.
Wonderful, thank you. Another question here about BNP. Can it be used to stratify risk, especially with patients with early disease? Could we use it as a way to encourage patients to work on lifestyle modifications before they develop heart failure?
Oh, that's, yes, definitely. We don't usually use it for that, but it can. Like Sheri was talking about, like stage A heart failure, they're just at risk of heart failure. You know, that's about half the population of North America is at risk of heart failure because they have hypertension or diabetes or obesity. But the patients who have like pre-heart failure, stage B heart failure. So they have some structural or functional abnormality of their heart, but they've never actually developed symptoms and signs of congestion. So in those patients, I think the BNP could be very useful to identify patients who are more likely to go on to develop heart failure, stage C heart failure. So I think that is a very good, that's a very good point, that you could use the BNP, like the study that Sheri showed, as a biomarker of increased likelihood of developing heart failure. And they used a very low BNP in that study as well.
Great. So another question here about BNP and the changes. Does it change daily, hourly, monthly? What can we be expecting from those changes?
Oh, the BNP, it's kind of more weekly, I would say. Like it's not immediate. So if someone develops acute pulmonary edema, for example, with an acute infarct or with papillary muscle rupture, the BNP will be normal and they'll be presenting with florid pulmonary edema, but that's more in the emergency department because they're in respiratory failure. So I would expect the BNP to respond more kind of on a weekly basis. So when someone comes into hospital, they'll have a really high BNP, and before they go home, the BNP should be significantly decreased, although still elevated.
Hello, I wondered how quickly does the lab report results, and what is BNP called in Calgary again?
It's the NT proBNP. That's the type of BNP that they have an assay for in the Calgary region. What was the other question? How quickly it's reported? Within 24 hours.
Oh, good. Great, thanks.
Or like a troponin, you know, you think of BNP, you know, troponin, you think of myocardial injury, think of BNP as the biomarker for heart failure.
you so much, Dr. Cujec. Another question here. For patients with right-sided heart failure and sleep apnea, how do you know that their sleep apnea is adequately treated? Is being on CPAP a risk factor on its own?
Well, I would be concerned if the patient has right heart failure. That means an elevated jugular venous pressure and peripheral edema. And if the only reason for the right heart failure is pulmonary hypertension related to sleep apnea, I would be concerned that the sleep apnea is not adequately treated. So we'd probably recommend another sleep test.
Wonderful, thank you. And just another question here about screening. One of the docs hadn't heard of any randomized control trial data or guidelines supporting screening for heart failure in asymptomatic patients. And they were just wondering where that might come in. Asymptomatic patients would most likely have HFpEF, and none of the medications have been shown to have a mortality benefit in this population.
Well, that's a very good question. So yeah, I would not recommend screening for heart failure in asymptomatic patients if they only have risk factors for heart failure. So, you know, the risk factors, so that's kind of like a stage A of heart failure, which is half the population. So the risk factors are basically hypertension and diabetes and obesity, smoking. They're the risk factors for vascular disease. And then to that you add like chemotherapy, patients who've had cancer in the past. So I have to say, like for chemotherapy, we do periodic screening with echocardiography, but for vascular risk factors, we just recommend treatment as per guidelines. Now the kind of stage B heart failure, or that would be the pre-heart failure category. So these are patients who have structural heart disease, but no symptoms associated with it. So there we do have evidence that, for example, ACE inhibitors and beta blockers prevent mostly hospitalizations for heart failure. That's stage B. But the real game changer has been the SGLT2 inhibitors. So I would say in patients who have diabetes, say they're, you know, risk factors, that's a risk factor for heart failure, I would recommend they be started on SGLT2 inhibitor pretty quickly, right after metformin, as long as they can pay for it, because it may not be covered. So I think that's that. I wouldn't say screen for heart failure. I would say try to prevent. There is evidence, of course, that SGLT2 inhibitors prevent hospitalizations for heart failure and improve cardiovascular survival in pre-heart failure. So just diabetes.
Thank you so much. We have time for about one more question, if there are any other questions. Oh, we've got one from Dr. Young. Is it recommended to follow serial BNPs to monitor progress while in hospital?
Yes, it is. Not every day, but you usually get a BNP when they're admitted to hospital and then like the day prior to discharge, so that you have evidence of improvement in filling pressures. And then if the BNP is still really as high as when they came in, it's probably better to keep them in hospital. Serial BNP in the community for the same reason, yes, for sure. You would repeat it like to assess response to therapy.
Fantastic. Great. And thank you everyone for your patience as we kind of jumped around for the presentation here. I know there might be some questions that are still coming in. We are going to move on to the next portion, but we can always pass those along to Dr. Cujec and Sheri and just see if they can respond in our follow-up email. There was a question about slides being emailed out. Absolutely. And the recording as well. So hopefully it'll be a little bit clearer if there was anything that was missed.
Great. Thank you so much to Dr. Cujec and Dr. Koshman and to Heather for helping coordinate everything. We're going to move right on into our application of learning section. So in a few minutes, you will be assigned to a facilitated breakout room where you will receive support completing an action plan. And the action plan is looking at turning what we've learned tonight into practical change that can help screen our patients for heart failure and prevent heart failure for patients who do have risk factors. And we're going to be asking these 4 questions on the action plan. So first of all, which patient would you like to screen in your practice? We know we heard a lot of risk factors tonight for heart failure. So these are some of the risk factors that are on your action plan. And you can go through and decide if you would like to include all of these, or if you'd like to limit it to perhaps only those patients who are at stage A or stage B, or even add additional risk factors. As was mentioned, we would then recommend using some of the discussion and recommendations today to apply prevention-focused therapy to those patients who have risk factors, which may include a screen for exertional dyspnea or exercise intolerance, and sending appropriate patients on for additional screening that was discussed. So once we know which patients we would like to screen, and generally the clinical process once you have that patient in front of you, we want to ask ourselves, how will we identify the patient? So how will we know if a patient is coming in to see us and has some of those risk factors? And when we talk about applying a systematic approach, we generally talk about 2 ways of doing this, using an opportunistic or an outreach approach to screening. In an opportunistic approach, there's a flag on the chart that alerts us that a patient has a risk factor for heart failure and is already coming in for a regularly scheduled appointment. And seeing that flag on the chart, we would use a planned workflow to promote heart failure prevention and screening. What this looks like is a patient may be in front of us for a pre-booked appointment. It might be a medication refill, a complete medical. Their chart does show and flag that they have some risk factors. And so the clinician has an alert pop up on the chart. In some electronic medical records, this alert can be satisfied by using certain phrases or a macro in our chart notes. In others, like this example here is MedAccess, you can even design it so you click right on the alert. It has the questions you decide to ask the patient pre-populated in it. So all you have to do is ask those questions and then click save, and it is removed from that patient's chart. Alternatively, we could use an outreach approach where we generate a list of all of our patients who have risk factors for heart failure, and we book those patients in for risk reduction or health promotion appointment. So this might look like generating a list of patients with the risk factors, looking at how many patients there are, and then we have a patient at home who has some risk factors, and the most appropriate team member is going to call that patient. That could be a receptionist calling the patient to book in for a telephone consult with a physician or an in-clinic visit with the physician. It could be a clinic nurse who's calling the patient and doing some of that pre-screening and health promotion appointment over the phone, and then either booking patients in for the physical part of the appointment with the physician, or even screening patients, so only patients with certain risk factors or have additional health concerns are then booked on in with the physician. So looking at our team and what's the best use of our resources and who is the best person to be calling those patients. So I'd like you to enter in the chat, looking at these 2 approaches, if you can enter which one seems like it would work best for your panel in your clinic. So if you enter 1 for opportunistic or 2 for outreach, and your facilitator of your breakout room is going to take that information and use it to get your action plan started in the background here. So some factors you might consider are the resources you have available at your clinic and your access that you have in booking appointments at your clinic. So again, 1 for opportunistic and 2 for outreach. And while you're entering that, I'm just going to discuss the last question we're going to ask is, how will you measure your improvement? So whenever we put a change in place, we want to make sure that we're looking at that and saying, is the change actually effective? Is it making a difference? Is there anything that we'd like to modify? And When we look at measurement in quality improvement and in primary care, it's different than measurement in research. So we're not looking at having huge sample sizes. We are looking at instead doing rapid tests of change. So trying something out for a select number of patients or a short period of time, and then evaluating to see if it seems to be working and making any changes we need. So for the purposes of this project, that could be as simple as doing a 5-patient chart audit. So trying out your screening process with 5 patients and then reflecting if that was helpful for those patients, if it led to any further discussion, if it felt natural, and then possibly modifying your process based on that. For some of our EMR clinics, if you want to go a bit more in depth, if you're using an opportunistic approach, you might look at the percentage of patients who presented to clinic in a time period who had risk factors and actually received a heart failure review. I'll learn the chart, but how are we actually clicking on it, looking at it, and making sure those patients get screened. For an outreach approach, similarly, you might get the percentage of at-risk patients who did receive an outreach phone call within a month. So again, it's great that we pulled a list of the patients, but we're able to find the resources and the access to get those. And finally, if you want to do a little bit more of an in-depth measurement, you could even look at of the patients who received a heart failure screening review appointment, how many of those actually did receive some requisitions or some action for further screening, further testing. So possibly had some symptoms or for on, again, we wouldn't expect this to be 100%, but you might look at it and see if, is this making a difference, and am I using this review to make some additional referrals for my patients. So about just over a 10-minute break, we're going to do now and create the action plan, and then we'll join back here just for a closing slide and evaluation.
All right, everyone, as they're joining their rooms, there we go. And so welcome back.
Great, thanks everyone. And I'll just let you know in the chat in a few moments, there will be a link for evaluation. So please go ahead and click that once you see that. We also would like to just let you know your next steps for this webinar are that your PCN QI team will connect with you about starting your action plan if you were in one of the facilitated groups where you actually filled out the action plan. We encourage you to try out the process that you developed and to complete your CME record of hours form, indicating when you met with your team and when you put your action plan into place and how you decided to evaluate it. And then we would encourage you all to join us for part 2 of this webinar series on April 20th. And that one will be on the management of heart failure in primary care for the same time. So please take this time to do our brief evaluation. You can click the link that's in the chat, or you can use your phone and scan the QR code here. Thank you so much for joining us tonight, everyone.